Dear friends, it's indeed a great honor to be invited to this event to celebrate the illustrious career of Professor Simon Davies as he steps into the well-deserved phase of retirement. Of course, this has a bittersweet feeling to it. From my perspective, I can firmly say that Simon is not just a colleague, but also a beacon in the field of nephrology and dialysis. Beyond the accolades and recognitions for his work, Simon's humanitarian commitment, driven by a profound sense of desire to improve the lives of those suffering from kidney diseases, is definitely worth emulating for all the young colleagues who might be there in the room today and those worldwide who might listen to this. Simon, your legacy is not just in the papers and the accolades, but in the patients whose lives you have touched, the colleagues you have inspired, and the mentees whose careers you have shaped. You have set a standard of excellence, compassion, and leadership that will continue to guide us. I hope that retirement does not mean that you ride off in some sort of a sunset, but that you would perhaps be even more available to help improve the delivery of kidney care to which we are all committed. I'm indeed very sorry that I cannot be in the room there with all of you in person, but thank you very much for the opportunity to join this event from my home in India. So Simon asked me to talk about the framework that Simon, David Harris, Fred Finkelstein, and other colleagues started to develop for providing care for patients with end-stage kidney failure as part of our ISN initiative. So the work at the ISN has moved on since then and has become much broader, and I'm going to present some of that to you today. Everyone in the room is aware that soon after it became clear that dialysis could be performed as a chronic therapy in the 1960s, insufficient funding emerged as the major barrier to accessing treatment beyond a few people who were really considered to be lucky at that time. The presumption that funding could allow relatively young and employed tax-paying members of the society to be rehabilitated and return to work led to a public debate in the US, which culminated in the passage of the Social Security Amendment or the Medicare Act by the Congress in 1972. The removal of financial barriers laid the foundation for the rapid expansion of dialysis programs in the US and later on in the rest of the developed world, to the extent that access to dialysis is now used globally as a benchmark for societal willingness to pay for medical care. And there are these statements such as this taken from the CARE guideline that dialysis should not be withheld either because of availability of resources or a risk of potential litigation. However, soon after its inception in the US, the financial burden was recognized very quickly, and it became very clear that it is one of the most expensive medical procedures around. Within less than a year, New York Times went on to call Medicare as Medicare-lessness and made a number of statements that resonate in many countries that are trying to set up dialysis programs around the world to this day. According to this analysis that some of my colleagues at the George Institute did, it was found that more people experience catastrophic healthcare expenditure as a result of treatment for kidney disease compared to any other chronic disease group. And again, data since then has shown that one of the worst kept secrets in global nephrology is that the global healthcare community is able to provide treatment only to a minority of patients with end-stage kidney failure who need it, and the rest of them all die without access to treatment. This systematic review showed the huge gap between the prevalence of kidney replacement therapy around the world, amounting to more than 1,000-fold. The kidney replacement therapy availability was close to zero in parts of Pacific Islands and Africa, and as high as more than 2,000 per million population in parts of North and East Asia. Moreover, most of the people receiving kidney replacement therapy live in the developed world, and less than 7% of dialysis population lives in low and lower middle income countries, which constitute 70% of the world population. This slide, once again conducted as a part of the ISN exercise, at looking at end-stage kidney disease care shows very interesting differences between the prevalence and incidence of kidney replacement therapy in different country income groups. So you can see different modalities, end-stage kidney disease, hemodialysis, peritoneal dialysis, transplantation, etc., grouped between high-income countries and non-high-income countries. And you can see that there is a significant difference in the prevalence of all of these therapies between the two groups of countries. Whereas if you look at the incidence, there is not much difference, which means that the number of new people who require treatment is more or less the same, and most of them are able to at least access treatment at one time. But many of them fall off during the course of treatment, which reduces the prevalence, whereas the incidence is not so different. So this is something which has also been confirmed in the systematic review on treatment patterns of people with end-stage kidney failure in sub-Saharan Africa. And these authors showed that only about 1% of all incident patients who started dialysis in sub-Saharan Africa were able to continue dialysis beyond 1 year. And the authors concluded that more equitable and sustainable strategies to manage individuals with end-stage kidney failure were needed in sub-Saharan Africa. And I'm going to illustrate all of these points with just this one simple story, because a picture, in this case a story, says a million words or more, and I'll just shut up and let you hear the story of this unfortunate patient.
नींद बहुत आती है, खाना नहीं खा सकती हो, उल्टियाँ आती है। उम्र जी मेरी 38 साल है और मतलब डॉक्टर ने दिखाने गई, पहले मेरी बीपी आई हो या फिर मेरी किडनी खराब हो गई थी जी, ठीक है। और फिर मैं बिल्डिंग शुरू हो गई थी जी, फिर डायलिसिस के लिए जी। डॉक्टर ने जी मेरे को 3 डायलिसिस के लिए बोला है, मैं एक ही डायलिसिस ले पाती हूँ, पैसे कारण भी पैसे का जुगाड़ नहीं। बच्चों पे जी पढ़ाई नहीं हो पाई है, लड़की पढ़ने से घर बैठी इस करके जी घर के खर्चे नहीं चल पा रहे बिल्कुल भी। मेरे डायलिसिस पे लग जाता सारा पैसा। मेरे को डायलिसिस फ्री हो जाएगी जी, मेरे को बहुत ही फायदा है, बहुत पैसा लगता है जी। भी मैं ठीक हो जाऊँ, अपने बच्चों में सही रहूँ। कौन नहीं चाहता भी अपने बच्चों में सही रहे, सब चाहते हैं।
Middle-income countries with limited resources, prioritization of kidney replacement therapy, of course, is a contentious issue and needs to be balanced against other pressing societal needs, which include livelihood, sanitation, clean water, and prevention and treatment of infectious diseases, providing adequate obstetric care, etc. Different factors motivate different actors involved in making, interpret, and executing policies. And most of us are familiar with the things that motivate these different actors. The variability in these approaches may also be different due to a number of other factors, which include human resources, cost structures, for example, the relative cost of labor and supplies, which may be different in different parts of the world. There are differences in cultural and religious considerations. Of course, the political context is different. Not to forget the competing interests from other stakeholders, which include drug and device companies, dialysis providers, and not the least, the nephrology colleagues and other healthcare workers as well. So with that background, the ISN had put together an ESKD summit to discuss all of those issues in 2018, where more than 80 stakeholders from around the world came together. Dr. Simon Davies was one of the leaders, and it led to a series of publications which discussed the different aspects of these issues. The summit was focused in its deliberations around the dimensions of universal health coverage. And these dimensions related to access to health services, financial risk protection, and not the least of all, quality of services, ensuring that all the services that we discuss should be both adequate and effective as well. The participants uniformly agreed that if resource constraints were not present, end-stage kidney failure should be available as an integrated mix of the two dialysis modalities, also kidney transplantation and conservative care, and that patients should be able to choose and transition between these different modalities. We now recognize that countries are responding to these challenges in different ways with variable provisions of the components of this kidney care strategy. However, the group also unanimously recognized that decisions to establish dialysis services without sufficient consideration of the other upstream components of kidney care, such as prevention of kidney disease and measures to slow progression and prevention of complications, were really of particular concern. And it was recognized that these decisions were often made without effective representation and guidance from the kidney care community by politicians or non-healthcare actors in these societies as well. The group came up with this triangle in which the size of each section of the triangle was drawn to be in proportion to the associated health gains, and thus recommended priority for investment. And I draw your attention just to the top part of this triangle, which talks about the treatment options for patients with kidney failure. And we make the point, again, as illustrated by the size of the different components, that amongst the kidney replacement therapy modalities, given that transplantation offers for all suitable patients the best outcomes at the lowest costs, and therefore it should be prioritized. Between the two dialysis modalities, the choice to favor hemo and peritoneal dialysis, it was agreed that it should be based on local health economic studies, but also recognizing that wherever local health economic studies have been done, peritoneal dialysis has been shown to be more cost effective to the healthcare system than hemodialysis. And the participants said that the current approach to kidney care is neither sufficient nor sustainable, and therefore it requires urgent attention of all stakeholders, which include governments, policymakers, and the medical communities. This next slide shows obviously something that we all know very well, that despite the fact that priority investment goes from kidney transplantation through peritoneal dialysis to hemodialysis, it is actually hemodialysis which is the most utilized form of kidney replacement therapy worldwide. And that even though proper health economic evidence from high income countries shows PD to be cost effective, the actual cost of delivery of peritoneal dialysis and hemodialysis are variable worldwide. It's not that hemodialysis is cheaper in certain countries, but that the cost of peritoneal dialysis is higher, making this ratio skew in favor of hemodialysis in certain countries. And those are the countries which need to develop expanded therapy the most. The International Society of Nephrology 2 years ago developed this framework on setting up of dialysis settings in low resource settings. This was just an initial work and remains a work in progress, and subsequent work that is being developed by the ISN in collaboration with other groups as a part of its work program for the WHO is planning to further expand on this. And again, Dr. Simon Davies is a big part of that. We come back to this slide, but this time I would like to focus on the bottom of this triangle. And this triangle makes the point that given that the cost per quality adjusted life years, or QALY as we know, which is associated with providing preventive care, is markedly more favorable than dialysis care, it is indeed rational to prioritize publicly funded preventative care rather than publicly funded publicly funded kidney replacement therapy care. We recognize that private sector has expanded quite substantially in many developing countries and is increasingly providing kidney replacement therapies. Now, for preventative care, kidney disease has been largely ignored by most governments and even multilaterals like the WHO for a long time. The WHO has, of course, come out with a list of best buys that focus on diabetes, cardiovascular disease, cancer, and chronic respiratory diseases. And kidney disease was not really included under the argument that these best buys would help to prevent progressive loss of kidney function anyway, and therefore they will favorably influence the burden of end-stage kidney failure. However, we now know that there is no agreed best buy list of diagnostic tests or treatments of kidney disease. Now, to be maximally useful to decision makers in low-middle income countries, new types of evidence, which include rapid reviews, economic analysis, are required, which will provide updated and accessible information to support decision making on kidney care programs. And this is what the ISN has been engaged in the last couple of years. And in the last year, 3 of these publications came out. The central publication is really the one that I would like to draw your attention to, which was published in the Kidney International last year, which provides perspectives on early detection of chronic kidney disease. It was supported by a scoping review shown here on the left and a series of case studies shown here on the right. And this framework developed a list of questions for the healthcare system administrators, which are listed here. And rather than to provide a solution by itself, it really prompts all the stakeholders to develop the solutions for themselves in light of the answers that will come for these questions that are listed here. I won't go into the details, and once again, it's published in Kidney International last year. And based on the answers to these questions, the group suggests an evidence-based, resource-sensitive framework that can be adjusted to suit local context. And the essential points related to that framework, again, are listed in this box here. We also emphasize the need to ensure that supportive care or palliative care should be seen as an essential and integral component of comprehensive end-stage kidney disease care. And it is something that we should learn from our colleagues in oncology and colleagues who have been managing patients with AIDS, etc. All this approach requires coordinated advocacy, and this paper, developed in collaboration by the ISN with American Society of Nephrology, European Renal Association, regional societies such as SLAN, APSN, AFRAN, and many national societies, attempts to marshal arguments to shore up global support for prioritizing kidney care, including from multilaterals like the WHO, and WHO is a particular target here. Because the ISN Global Kidney Health Atlas data has shown that kidney care is not in the list of national priorities for most countries, and inclusion into priority listing from the WHO can go a long way in addressing that gap, because individual countries often follow the recommendations of the WHO. We also need to show the governments as kidney care community what works and why does it work. If something does not work, why does it not work? We all know the challenge with implementation research and translating research finding into practice. All of the people who are there in the room there have spent their lives trying to answer these questions. Sustainable models of care are now being developed, but need to generate the evidence of their efficacy, effectiveness, scalability, and sustainability. I don't have, unfortunately, time to go into the details of those initiatives which are being implemented by many colleagues, including ourselves, but surely those initiatives will generate more evidence which will help setting up of these programs. So, as I conclude, we must ask, where do we go from here? These are the building blocks that were used by the ISN End-Stage Kidney Failure Strategy Group, and all the outputs that have come out have been based on these WHO health systems building blocks. And These outputs have been shaped by these underpinning principles, and these principles include solidarity, social justice, universal access, the need for multi-sectoral action in collaboration with the communities and in line with the values and preferences of these communities and the society. And these are the kind of values and principles that Simon has exhibited throughout his career. So therefore, my dear friends, I conclude my presentation here and once again congratulate Simon for a brilliant career and the friendship. Thank you very much.